The role of radiological imaging in workup of locally advanced breast cancer case presentation series will be presented by Dr. Sara Isam Hamad Tawfiq. Dr. Sara is the consultant radiologist. She is graduated in, she has MD in diagnostic radiology from Sudan Medical Specialization Board. She worked as a radiologist in Khartoum Breast Care Center, and now she is a radiologist in Khasab Hospital in Sultanate of Oman. You're welcome, Dr. Sarah. You can start.
يعني أنا سعيدة جدا بالفرصة اللي أتيحت لي دي، وسعيدة جدا إنه يعني أجتمع مع الوجوه والأصوات اللي ارتبطنا بها لسنين طويلة. بسم الله الرحمن الرحيم. نبدأ. الصلاة والسلام على رسول الله. As we know, as was mentioned by Dr. Malcolin and Dr. Rabab, the locally advanced breast cancers, heterogeneous group of breast tumors that share a common theme of extensive locoregional spread without overt evidence of distant metastatic disease. Locally advanced breast cancers are also identified by the anatomic extent of disease, usually stage 3B and 3C, whereas some clinicians include patients with 3A disease into the locally advanced breast cancer definition. Locally advanced breast cancer also include inflammatory breast carcinoma, as defined by ADCC or UICC systems. This is the ADCC stages of local advanced breast cancers. I will not mention them, but just there are stage 3A, 3B, and 3C, as mentioned in the previous lectures. What is a radiology role in imaging, radiological imaging as a part of multidisciplinary team? As we know, the radiological imaging is regarded one of the cornerstones in diagnostic, staging, and management of breast cancer. And once a tissue diagnosis of local advanced breast cancer is established, patients should undergo multidisciplinary review before treatment. The multidisciplinary team should include surgical, medical, and radiation oncologists, pathologists, radiologists, and plastic surgeons, creating and delivering a unified treatment proposal to the patient. Because of low yield cost and distress associated with investigating detective abnormalities that are for the most part false positive, baseline systemic staging is neither before nor recommended before surgery and auxiliary staging in patients with early stage breast cancer. In the patient with more advanced disease, such as locally advanced breast cancer and inflammatory breast cancer, some evidence support the use of systemic imaging at the initial staging to detect distant metastasis, which has a considerable clinical impact by upstaging the patient to stage 4 disease, which would significantly alter treatment options from curative intent therapy by surgery with or without neoadjuvant therapy for the local regional disease to palliative systemic therapy. And some studies showed that the yield of metastatic workup in asymptomatic early breast cancer patient is approximately 2 to 3%, but this risk raises to 30% in locally advanced breast cancer patients. Locally advanced breast cancer has a high percentage of metastatic disease, which would be undetermined clinically, and this suggesting do a radiological systematic workup for detection of metastatic disease. And according to the American Joint Committee on Cancer, the TNM system regarding breast cancer, they said breast cancer diagnosis is based on histological assessment of the primary tumor or metastasis, whereas staging and evaluating the extent of visceral, nodal, and bone disease is determined largely on imaging. As you know, the category M is classified as M0, no distant metastasis, or M1 metastatic disease present. The most common sites of metastasis in breast cancer are bone, lung, brain, and liver, in that order. The AGCC guidelines of their last edition clarified that pathological M0 is not a valid category. A benign biopsy of a suspicious lesion do not guarantee absence of metastatic disease elsewhere. Only clinical M0, clinical M1, and pathological M1 are used. Category clinical M0 is defined as no clinical or imaging evidence of distant metastasis. Category clinical CM1 is defined as distant metastasis on the basis of clinical or imaging finding. Category B M1 is defined as distant metastasis on the basis of pathological growth. So in order to exclude systemic disease, we should do systematic imaging. There are several national and international guidelines developed, changed, and updated over many years for imaging protocols that used in initial staging and restaging of breast cancer. We will go quickly through the most important guidelines. NCCN guidelines state that routine systemic staging is not indicated for early breast cancer or in
معلش
the
يا جماعة
absence
احنا ما
of
سامعين حاجة، الصوت ما في.
لا أنا سامع.
We can hear it, yeah.
We can hear
أيوة.
they
you.
said that routine systematic staging سامعين؟
أيوة سامعينك يا
أيوة
دكتورة،
سامعين يا
واصلة.
واضح
سارة.
واضح يا سارة، continue.
سامعين الصوت
Okay.
واضح، سامعين.
أيوة واضح.
The NCC guideline said that the routine systematic staging is not in the absence of signs of and symptoms of metastatic disease is not indicated. And additional studies are guided by patient symptoms. And for patients with clinical stage 3A disease or those considering neoadjuvant chemotherapy for T2 M0 or higher, or N1 M0 or higher disease, studies to consider include CT chest, abdominopelvic CT, or MRI, bone scan, and FDG PET CT. When used in addition to other imaging studies, FDG PET CT is helpful in identifying and detecting regional nodal disease or distant metastasis. Systemic imaging is also recommended in recurrent disease, for M1 disease or inflammatory breast cancer. Another guideline for the Royal College of Radiologists, they do not advocate routine staging imaging for asymptomatic patients with early stage disease. And only imaging is usually reserved for those patients with more advanced cancer at high risk of metastasis. RCR guidelines further recommended computerized tomography of the thorax, abdomen, pelvis, with or without bone scintigraphy for staging of patients with large T4 tumor, heavy burden of nodal disease, or symptoms attributed to metastatic disease. PET CT is recommended in cases of suspected inflammatory breast cancer because they have higher risk of metastasis. This is supported by Van Ouden et al. In their recent systematic review, demonstrating that FDG PET CT outperform conventional imaging in the detection of leukoregional and distant metastasis in the initial diagnostic workup of locally advanced inflammatory breast cancer. Another guideline from the European Society of Medical Oncology recommended clinical history, physical examination, hematology, and biochemistry tests together with imaging of the skeleton, chest and abdomen at the minimal staging workup in patients at high risk of developing metastatic disease. The ISMO guidelines also recommend performing chest and abdominal imaging, ultrasound CT or MRI scan, and the bone scan can be considered for patients with clinically positive axillary lymph nodes, large tumors, T3 and 4, or tumors with aggressive biology. If such methods are inconclusive, dual imaging method combining functional and anatomical information such as FDG PET scan are suggested. The last guideline I will mention is the National Institute for Health and Care Excellence, NICE guidelines. They recommend CT, magnetic resonance imaging, ultrasound, and plain radiography to assess the extent of visceral disease. For bone disease, bone scan, CT or MRI is recommended. And FDG PET CT, this setting should be employed only when conventional imaging findings are inconclusive or suspicious. So as you noted, recently the plain radiography, it have a minimal role nowadays in initial the aesthetic workup. As you know, in chest X-ray, they're less sensitive for pulmonary nodules and cannot assess mediastinal structure and mediastinal lymphadenopathy. Also, the bone X-ray for bone needs about 30% of demineralization to detect metastasis. The imaging modalities which are used for systematic staging of locally advanced breast cancer, including conventional imaging, including the radionuclide bone scan, CT, and MRI, and the advanced imaging include PET CT, PET MRI, and whole body MRI. We'll go to discuss the yield of them in brief. The conventional imaging we'll start with radionuclide bone scan. Planar bone scintigraphy is clinically easy to read, widely available, and cost-effective. It has been recommended as the primary technique to detect bone metastasis in asymptomatic high-risk breast cancer women. Abnormal accumulation of technetium 99 level diphosphonate is connected to increased local blood flow and osteoblastic activity, which occur consequently to metastatic growth within the bone marrow. The sensitivity of bone scan reportedly range between 62 to 100%. However, technetium 99 level diphosphonate are non-specific marker of osteoblastic activity, which are also observed in benign fractures, Paget disease, degenerative joint disease, trauma, and inflammation. This accounts for the lower specificity of bone scan than SPECT, which has more specificity. SPECT is bone scan, and this is another method of detecting bone metastasis. An overall improvement was observed when bone scan was augmented using single photon emission computerized tomography SPECT in the lower thoracic and lumbar spine or across the entire axial skeleton, whole body SPECT. On a per patient basis in breast cancer, SPECT shows